Welcome to the debate. In early 2024, a really highly promising biotech company was essentially forced to terminate over 90% of its workforce.
Yeah, which was just a massive shock to the industry.
It really was, and the wild thing is, it wasn't because their clinical asset was toxic, and, well, it wasn't because they lacked initial funding either. It was because they lost this microscopic war against an evolutionary defense system that is, frankly, as old as humanity itself.
Right, because usually when we talk about developing a new pharmaceutical drug, there is this underlying expectation of engineering on a blank canvas.
Exactly. You design a small molecule, it enters the bloodstream, binds to a receptor, and it alters a biochemical pathway. It's an isolated, mostly predictable transaction.
Yeah, and it relies on a highly controlled environment. We've historically really liked to view the human body as this, I don't know, passive vessel just waiting to receive chemical instructions.
But then, you step into the world of microbiome-based therapeutics, and suddenly that blank canvas just vanishes. We are no longer building on an empty lot. We are trying to construct a really delicate piece of metabolic architecture right in the middle of a densely populated, fiercely competitive, and highly hostile biological jungle.
A jungle is the perfect word for it. It is the absolute definition of a paradigm in collision. Biology is pushing back incredibly hard against technology.
It is. So today we are looking directly at this frontier. It's a rapidly evolving field characterized by these historic regulatory breakthroughs, which are existing right alongside those high-profile corporate insolvencies.
And we're drawing our discussion today directly from recent clinical trial data, regulatory milestones up to mid-2026, and some really advanced microbial ecology research.
Right. So the central question we are unpacking today is this. Will rationally designed microbial consortia and, genetically engineered live biotherapeutic products fundamentally transform the treatment of chronic systemic diseases, or, and this is the flip side, are these living therapies inherently constrained by the human gut's evolutionary defenses? Meaning, does their success rely exclusively on what we might call ecological vacuums?
It's a huge question.
It is. And I represent the perspective of, let's call it, pharmaceutical optimism. The data suggests to me that through synthetic biology and computational ecology, we can and we will overcome native biological limitations to cure complex systemic diseases.
And I represent the perspective of ecological reality. My position is that the inherent phenomena of colonization resistance, along with the severe metabolic burden placed on engineered strains, they present nearly insurmountable barriers to engrafting exogenous microbes into an intact human gut.
Okay, so let's lay out our positions clearly to start. From my perspective, the field of microbiome therapeutics has successfully matured from, a promising academic concept into a concrete, validated regulatory reality.
You're pointing to the recent FDA approvals, I assume.
Exactly. We are no longer just theorizing. We have the FDA approvals of Ryota in 2022 and VOST in 2023. And these aren't just incremental steps, right? They are definitive proofs that live biotherapeutics can meet and even exceed really rigorous clinical standards.
Well, sure, they met the standards for one specific condition.
True, but hear me out. Yes, we've seen early generation failures when companies relied on rudimentary approaches, but the field is advancing exponentially now. We are deploying advanced computational tools like the EPIX algorithm, and we're leveraging synthetic biology to rationally design programmable microbial drugs.
Programmable, yes, but in a very messy environment.
But that's the point of the precision. By precisely defining strains that can actually navigate complex interspecies competition, we are paving the way to treat metabolic disorders, autoimmune conditions, and far beyond.
Okay, but see, I look at the exact same regulatory landscape and I see a profound biological barrier that we simply cannot code our way out of.
You mean the native ecosystem?
Exactly. The human microbiome is a fiercely resilient ecosystem. It's defined by a phenomenon known as colonization resistance. This isn't just, passive crowding. It is an ancient, active evolutionary defense mechanism.
Active in what ways specifically?
Well, resident commensal bacteria actively repel invaders through spatial niche exclusion, meaning if you think of the gut lining like a parking lot, every single space is taken. A new vehicle physically cannot park.
Ah, I see.
Yeah, and they aggressively lower the luminal pH to create acidic environments that are toxic to newcomers. Plus, they deploy these antimicrobial weapons called bacteriocins.
Which act essentially like molecular shibs, correct? Basically puncturing the cell walls of competing bacteria.
Exactly. Molecular shivs that target highly specific competitors. And it goes even further than that. The native flora actually modulates the host's immune system to produce mucosal IgA and defensins.
Right, the specialized proteins.
Right. Those proteins fortify the gut barrier against anything unrecognized. So my core argument today is that the only reason Rebiota and Vowst succeeded in treating recurrent C. diff infection, or RCDI, is because standard of care broad-spectrum antibiotics had already completely obliterated that endogenous microbiome.
You're saying they needed a clean slate.
Yes, the therapies didn't conquer the jungle. They were planted after a massive forest fire, attempting to introduce exogenous bacteria into a replete, fully intact put's biologically doomed. And I think the catastrophic clinical failures of companies attempting to treat systemic diseases over the last few years totally demonstrate that.
Okay, well, let's drill down right into those first wave approvals. Because the interpretation of that RCDI data is really the absolute crux of our divergence here.
It really is.
So let's look at the actual clinical reality of C. diff. For patients suffering from recurrent C. diff, the stakes are literal life and death. The infection causes debilitating diarrhea, severe colon inflammation, and really high mortality rates.
Mostly because the pathogen forms those resilient spores that survive standard antibiotics.
Right. Now look at the clinical data for Vowst in this specific context. It is a defined consortium of roughly 50 firmicute spores. In the EcoSpore 3 trial, it dramatically reduced RCDI recurrence to just 12.4%.
Compared to, what, almost 40% for the placebo?
Exactly, 39.8% for the placebo. But what matters to me is how it does this. This isn't just throwing random bacteria at a wall to see what sticks. It is a highly specific, validated mechanism.
The bile acid metabolism pathway?
Precisely. So C. diff spores actually use the host's primary bile acids as a signal to germinate and start producing toxins. But the firmicute species in VOST, they possess an enzyme 7-alpha dehydroxylase.
Right, which does the conversion.
Yes, it converts those excess primary bile acids into secondary bile acids, and secondary bile acids actively inhibit C. diff growth. To me, this proves that we can rationally deliver a specific metabolic function to cure a severe disease.
I come at it from a different way. I fully agree the EcoSpore 3 data is exceptional, and the mechanism of bile acid conversion is elegantly proven. I mean, it's beautiful biology.
It really is.
But the context is the key constraint here. Treating RCDI relies entirely on exploiting a destroyed ecosystem. Just think about the patient journey for a second. They take Vowst after completing standard antibiotic therapy, right? And after undergoing a bowel cleansing regimen with magnesium citrate.
Yes, they do.
So the native flora is completely gone. Without those prior interventions wiping out the colonization resistance, those 50 firmicute spores would never engraft. They would be outcompeted for nutrients and repelled by the native ecosystem's defensive structures.
Well,
We absolutely cannot use an iatrogenic, medically induced ecological vacuum as proof that we can colonize a healthy, highly competitive gut.
That's an interesting point, though. I would frame it differently.
Okay, how so?
Well, just because the first successful interventions in a new medical modality require extreme conditions, that doesn't mean the modality itself is inherently limited. Let's look at a historical parallel. Think about the very first successful organ transplants.
Right, back in the mid-20th century.
Yeah. Early on, they required massive blunt force immunosuppression that left patients incredibly vulnerable to infection. But that didn't mean organ transplantation was destined to only ever work in patients with absolutely no immune system.
But
It just meant we hadn't mastered targeted immune modulation yet. Why assume the microbiome is any different? We are currently in the blunt force clearing phase, sure, but we are moving toward targeted modulation.
The reason we should assume it's different is because an organ doesn't actively evolve to repel another organ.
Okay, fair point.
The microbiome consists of trillions of living, competing organisms engaging in a continuous co-evolutionary arms race. Your transplanted kidney isn't trying to actively assassinate the host tissue, but commensal bacteria will actively assassinate exogenous strains to protect their nutrient supply.
True. They are highly competitive.
Right, but let's follow your premise that we can engineer our way out of this evolutionary reality. You naturally look towards synthetic biology for that, right?
I do, yes. Because synthetic biology allows us to bypass those native flora limitations entirely. We can give bacteria genetic instructions that native flora simply do not possess.
Genetic workarounds.
Exactly. If you're listening to this and wondering how we move beyond just treating gut infections to treating systemic diseases, this is the answer. We are seeing remarkable preclinical success in metabolic dysfunction-associated steatotic liver disease, or MASLD.
In murine models, yes.
Yes, in mouse models. Researchers engineered a well-known probiotic strain, E. coli Nissl 1917, to express insulin-like growth factor 1, or IGF-1, alongside a hormone analog called aldafermin.
And the results were pretty striking, I'll admit.
They really were. When delivered to these models, the engineered strains significantly accelerated recovery from MASLD. They reduced hepatic fat, they lowered plasma cholesterol, and fascinatingly, they actually increased bacterial diversity in the gut.
While upregulating beneficial short-chain fatty acids like acetate and propionate.
Exactly. We are talking about programming a microbe to act as a dynamic, in situ drug factory that chemically rebalances the entire gut-liver axis.
See, it works beautifully in a highly controlled murine model, but it hits a brick wall in the human gut due to the biological law of metabolic burden.
You think the burden is too high for efficacy?
I know it is. If you're wondering why we can't just give patients a daily engineered probiotic to solve complex metabolic diseases, you have to look at the math behind this metabolic burden. When you engineer a genetic device into a bacterium, like forcing it to produce IGF-1 and aldafermin, you place a massive, unnatural resource strain on that organism.
It requires energy, yes.
It requires massive amounts of ATP. Let's make this concrete. When you force a bacterium to produce a synthetic drug, it's like a startup blowing 100% of its venture capital on manufacturing a single product.
Leaving nothing for operations.
Exactly, leaving $0 to pay rent, keep the lights on, or defend against corporate espionage. The cell goes metabolically bankrupt. The energy required for the continuous transcription and translation of those synthetic pathways, it just prevents the microbe from allocating resources to basic survival and replication.
But if the therapeutic payload is delivered,
the payload doesn't matter if the factory burns down on day one. Let's go back to the story you opened the show with, that stark reality check, the high-profile collapse of SynLogic in early 2024.
right, the PKU trials.
Yeah. SynLogic engineered a strain, SYNB 1934, designed to consume toxic phenylalanine in the gastrointestinal tract to treat PKU, which is a severe metabolic disease. The engineered microbe was supposed to act as a metabolic sink for the toxin.
And it failed in phase 3.
It failed in phase 3. And crucially, it wasn't a safety issue. It was a profound lack of clinical efficacy. Because in the highly competitive human gut, the engineered strain could not maintain population density. Under intense interspecies selection pressure, inactivating mutations are strongly selected for.
Meaning they just shut off the synthemic gene.
Exactly. The bacteria will literally silence or drop the synthetic gene just to survive the neighborhood. Or they go metabolically bankrupt and are cleared entirely. Evolutionary biology wins. SynLogic had to cease operations and terminate over 90% of its workforce because they tried to fight millions of years of microbial ecology.
Well, I'm not convinced by that line of reasoning, because SynLogic's failure represents a first-generation design flaw. It's not an absolute biological ceiling.
A design flaw?
Yes. The assumption in that early model was that the microbe needed to permanently engraft, that it had to maintain wild-type survival rates while carrying this massive, heavy metabolic load. But advanced microbiome therapeutics do not necessarily require permanent colonization to be effective.
So you just pass them through?
Right. If the therapeutic effect, whether it is an immunomodulatory peptide or a localized metabolite, is delivered dynamically during the transit time before the strain clears, you still achieve the clinical outcome. You just dose it continuously, like a traditional small molecule drug.
But dosing it continuously didn't work for Synlogic. And it isn't just heavily engineered strains that are failing to achieve systemic effects. The industry has a veritable graveyard of ambition regarding interventions in intact microbiomes.
You're talking about the inflammation trials.
Yeah. Look at Evelo Biosciences. They tried to use orally administered microbial medicines to generate systemic immune modulation for inflammatory diseases.
I remember.
Their lead asset, EDP-1815, failed a phase 2 trial for atopic dermatitis in 2023. It missed its primary endpoint for eczema severity reduction. Then their next asset failed in psoriasis. The company dissolved.
And Vedanta had a similar setback.
Exactly. Vedanta's VE202, which was a rationally defined 16-strain consortium specifically targeted for ulcerative colitis. It failed phase 2 and was terminated because it couldn't demonstrate superiority over placebo in healing mucosal inflammation.
The active inflammation is a tough hurdle, I'll admit.
The lesson here is unambiguous. You cannot achieve meaningful ecological remodeling in patients with active, immune-driven mucosal inflammation. The inflamed tissue and the native dysbiotic flora act together as an actively hostile environment that shreds your therapeutic before it can act.
Okay, I will completely concede that attempting to cure chronic mucosal inflammation by simply adding a consortium to a replete gut has proven far more difficult than the industry anticipated. There is genuine intellectual humility required when looking at the Evelo and Vedanta UC outcomes.
Glad we agree on that.
But if an intact, inflamed immune system is the primary barrier, let's look at what happens when we medically modulate that environment. Let's pivot to where systemic intervention is not just working but actively saving lives that conventional medicine has essentially given up on: hematology and oncology.
You're referring to the stem cell transplant populations.
Yes, specifically patients suffering from graft versus host disease, or GVHD. Just to set the stakes for our listeners here, when a patient receives an allogeneic stem cell transplant, sometimes the donor's immune cells recognize the patient's own tissue as foreign and attack it.
Right, and in the gut, this causes a completely chaotic inflammatory storm.
Exactly. The mucosal barrier is practically shredded. So let's look at MAT Pharma's MAT-013. This is an off-the-shelf, standardized pooled donor therapy featuring a huge richness of over 450 species, and it's driven by a proprietary group of butyrate-producing bacteria.
And they targeted the most severe cases, right?
They targeted patients with severe, steroid-resistant gastrointestinal acute GVHD. These are patients who have failed multiple lines of therapy and historically have a median survival of just 28 days. But in the Phase 3 AIRS trial, MAT-013 achieved a 54% one-year overall survival rate.
I mean, that is a staggering improvement over 28 days.
It's incredible. Furthermore, there was a highly significant biological correlation. Patients who showed an early GI response to the microbiome therapy had a 68% one-year survival rate, compared to just 28% for non-responders.
And the mechanism relies on strengthening the gut barrier.
Right. The mechanism is fascinating. The butyrate-producing bacteria essentially feed the colonocytes, they strengthen the tight junctions of the gut lining, and they induce regulatory T cells to calm the inflammatory storm.
And Sigris has had a similar win in this space.
Yes, Ceres Therapeutics developed SER-155. It's an investigational oral live biotherapeutic product composed of 16 strains, designed to prevent bacterial bloodstream infections in these same stem cell transplant patients. It achieved an extraordinary 77% relative risk reduction in bloodstream infections compared to the placebo.
Wow.
Yeah, and it actively decreased fecal albumin, which proves it was successfully restoring the epithelial barrier integrity. This is undeniable systemic impact resulting from a gut intervention.
I'm sorry, but I just don't buy that this invalidates my core point about ecological constraints. Let me tell you why.
Go for it.
You are pointing to the exact phenomenon I described at the very beginning of our discussion. Think about who these patients are. They are individuals whose immune systems and mucosal barriers have been completely eradicated by intense pre-transplant conditioning regimens.
Chemotherapy and radiation.
Yes, chemo, radiation, and aggressive broad-spectrum antibiotics. You are proving the ecological vacuum thesis for me. MyArt-013 and SER-155 are brilliantly timed interventions that rush in to occupy a severely depleted mucosal niche, right before multi-drug-resistant pathogens can translocate into the bloodstream.
Well,
They work specifically because colonization resistance has been medically annihilated.
I see why you think that, but let me give you a different perspective. It is entirely true that right now, in 2026, we are utilizing clinical conditioning regimens to open the window for engraftment. But we are rapidly evolving beyond this reliance on blunt force ecosystem destruction.
Evolving how?
We are entering the era of computational ecology. We don't have to destroy the jungle with a forest fire anymore. We just need to know exactly which specific seeds will inherently outcompete the local flora.
And how exactly do you accurately model the combinatorial explosion of trillions of interacting microbes? When you have hundreds of species, the math behind mapping every interaction becomes impossible almost immediately.
It did, until very recently. You're right. If you try to evaluate the interactions of an N-species community using traditional methods, you are dealing with exponential experimental effort.
Right.
Imagine a petri dish with 5 different bacteria. Bacteria A, B, C, D, and E don't just interact one-on-one. Their metabolic byproducts constantly change the ambient pH and nutrient availability, which changes how they all interact with each other. It is combinatorial chaos.
So how do you solve for the chaos?
Well, researchers at the Indian Institute of Science developed the IPEX algorithm, effective pairwise interactions for community structure.
Okay.
It uses a top-down approach that simplifies these complex, high-order microbial interactions into effective pairwise interactions, while still accounting for the global environmental shift. They successfully validated this by mapping fifth-order interactions in an in vitro microbiome.
So they reduced the chaos to mathematically predictable pairs.
Exactly. We can now accurately predict the steady-state composition of massive microbial communities. We can rationally design synthetic consortia that actively outcompete native pathogens based on calculated niche overlap. We don't need a total vacuum if our computational models allow us to design a therapeutic consortium that is mathematically guaranteed to displace a specific pathogen network.
But that requires an unbelievable amount of local data to work.
And crucially, we have that now. This requires immense, diverse datasets. And that's why we are seeing massive regional diversification in data collection. Take BugSpeaks, for example. By early 2026, they had captured 90% of the Indian gut testing market.
Why is that regional dominance so important?
Because the Indian gut microbiome differs vastly from the Western gut due to distinct diets, environments, and genetics. You cannot apply an algorithm trained entirely on patients in Boston to patients in Bangalore. By integrating regional datasets like BugSpeaks into algorithms like EPICS, we are enabling truly geographically precise, targeted therapeutics that bypass the need for a vacuum.
That's a compelling argument on the theoretical side. But have you considered the physical and financial realities of actually trying to scale these computational marvels?
You mean manufacturing?
Yes. Let's say your EPICS algorithm designs the absolute perfect 16-strain defined consortium for a patient in Bangalore. You still have to manufacture it, and the manufacturing bottleneck in this industry is uniquely severe. Live biotherapeutic products are not small molecules. They aren't even monoclonal antibodies. They are living organisms that are exquisitely sensitive to oxygen, shear stress, and moisture.
True, but contract development and manufacturing organizations, or CDMOs, are rapidly scaling up specialized anaerobic fermentation capabilities to address this.
But at what physical and financial cost? Transitioning from a small bench-scale process to commercial production requires novel lyophilization techniques. When you freeze dry bacteria, iced crystals form and expand, and the shear stress literally tears the bacterial cell walls apart.
Which is why we use cryoprotectants.
Complex, expensive cryoprotectants. It requires highly advanced blister packs just to maintain microbial stability against moisture during shipping. Let's look at the financial fallout with Cirrus Therapeutics and Voust.
The divestment.
Yes, they achieved the ultimate goal. They got FDA approval, they had exceptional clinical data, and yet they had to divest Voust entirely to Nestlé Health Science at a staggering discount.
It was a $25 million buyout on future milestones, right?
Yes, on milestones that were originally valued at $275 million, and they had to fire a third of their workforce. Why did they do that? Because the cost of goods, the specialized anaerobic processing, the stringent purity testing for a living drug, it makes broad commercial scalability nearly impossible for smaller biotechs.
It's expensive, certainly.
You can have the best EPICS algorithm and regional bug-speaks data in the world, but if you cannot afford to manufacture the living drug at a scale that actually reaches the population, it is just a brilliant academic exercise.
The financial restructuring of Sira was undeniably a strategic move in a highly risk-averse biotech funding climate, but I wouldn't call it an invalidation of the manufacturing pipeline.
You think the infrastructure will catch up?
I know it will. The CDMO market for microbiome manufacturing is projected to nearly triple by 2033 precisely because the clinical demand and the capital are aligning to solve these scale-up challenges. Furthermore, we are aggressively shifting away from donor-derived therapies.
Because of the screening costs?
Right. Donor stool requires exorbitant pathogen screening and carries inherent batch-to-batch variability. Instead, we are moving toward rationally defined clonal LBPs, like Vedanta's VE303. VE303 is an 8-strain consortium derived from pure clonal cell banks. It bypasses the scalability constraints and transmission risks of donor stool entirely.
And the data on VE303 is promising.
It works beautifully. It showed an 80% reduction in the odds of RCDI recurrence in Phase 2 trials.
And I will genuinely celebrate VE303 if it passes Phase 3. But notice that VE303 is once again targeting RCDI. It is targeting an ecological vacuum.
We keep circling back to that.
We do, because we keep coming back to the exact same biological truth. Microbiome modulation is a validated, incredible science, but evolutionary biology always wins. The human gut is a fortress.
But
Until the pharmaceutical industry aligns its financial ambitions with the uncompromising laws of microbial ecology, until it fully accepts that these living therapies currently only thrive in medically induced vacuums, we are going to continue seeing costly late-stage failures in systemic diseases.
see, I look at those same failures, and I see an industry undergoing a painful yet entirely necessary paradigm shift. We are moving away from rudimentary donor-derived transfers and single-strain shots in the dark.
Toward the programmable models.
Exactly. By leveraging algorithms like EPICS, integrating regional data like BugSpeaks, utilizing precise microbiome disruption indices to quantify exactly when a patient's gut is vulnerable to intervention, and engineering sophisticated clonal LBPs, we are evolving. We are turning microbes into highly precise, programmable biological drugs. The ceiling is not colonization resistance. The ceiling is our current understanding of the ecosystem, and that understanding is expanding exponentially.
It seems we have reached a point of convergence, at the very least, on one fundamental reality. The simplistic early 2010s era of just adding good bacteria is definitively over.
Completely over. The friction between synthetic engineering and ancient ecological resistance is exactly what is forging the future of precision medicine in this space. For our listeners who are fascinated by the math and mechanics we touched on today, there is so much more to explore within the mid-2026 source material regarding how computational biology and microbiome disruption indices are actively reshaping the design of clinical trials.
Absolutely. It is a fascinating biological puzzle, and we are really only just finding the edge pieces.
It really is. It takes us right back to our opening thought. We are no longer trying to build a clean, isolated skyscraper on an empty lot. We are learning, slowly but surely, how to intelligently integrate our medical architecture into the deepest, most complex biological jungle on Earth.
Thank you for joining us on the debate.